all for being here with us today. It is great to be here to talk about this critical topic. It does not get talked about nearly enough. This is an issue near and dear to my heart. As many of you know, my sister is a nurse and has constantly pounded this issue into my head and into my heart. And so I am really excited for the opportunity for us to be discussing it today. We are one of the wealthiest countries in the history of the world. And yet, while every other developed country maternal mortality rate falls, ours rises. More than 700 women die each year in this country from causes related to pregnancy or childbirth. Up to 60% of these deaths are preventable. These numbers are shocking by themselves. The tragic reality is that within these numbers, Black women are up to 4 times more likely to die in pregnancy or childbirth than their white peers. This fact is staggering. It is unacceptable, and it is a moral imperative that we change it. I want to acknowledge that many people in this room have been having these conversations for years, some even decades. The problem has not been seriously addressed, and we have not been able to have meaningful, systematic changes. These disparities have not improved in 30 years. That said, I hope we are reaching a turning point. I am honored to be one of the founding members of the Black Maternal Health Caucus, where we aim to raise awareness of this issue as a national priority and advocate for effective, evidence-based cultural competency policies to finally address this devastating problem.
Thank you all for the warm welcome, and I want to thank Representative Omar, who is my sister in this work, a thought leader and a fellow breaker of concrete ceilings, for convening this really important conversation. And I also just want to thank each and every one of you. Throughout my campaign for Congress, I said that the people closest to the pain should be closest to the power, driving and informing the policy making. Please know that the reason why our sister colleague, Robin Kelly, introduced the Mommy's Act and why I introduced in partnership with Senator Booker the Healthy Mommy's Act has everything to do with the work that happens in community, the organizing, the mobilizing that pushes us and elevates consciousness to new issues. And so, the leadership that we are assuming in the corridors of power and at policy and decision-making tables is directly influenced by you. And I just wanted to underscore that, because when it does seem that we are drinking from a fire hose of insult and assault every day to our senses, to our humanity, to our democracy, to our planet, it's easy to be fatigued and to feel helpless. But just know that you are very powerful. And the fact that so many of you are here today is really a testament to just how much you care. And so I just want to say thank you for that. I also want to say
advocates and friends, and I look forward to having this great, wonderful conversation with them. So let me introduce our wonderful panelists. Dr. Rachel Hardiman, Assistant Professor in the Division of Public Health and Management here at the University of Minnesota School of Public Health. She is health equity research. She does health equity research, whose work is focused on the link between structural racism and health. Thank you, Dr. a midwife and the owner of Roots Community Birth Center, the only Black-owned birth center in Minnesota, and only one of 5 in the whole country. Next, we have Amira Adawe, who's a public health researcher whose work focuses on women, children's health, healthcare access, and chemical exposure. She is the founder and the executive director of Beauty Well Project that aims to combat skin lightening and chemical exposure in our state's immigrant communities. And finally, we have Dr. Helen Kim, prenatal physicist and director of Hennepin Healthcare Mother's Baby Program, the program that supports struggling pregnant women in the intersection between inherited historical trauma and rewriting those narratives for future generations.
This is what cultural competent care looks like, is not diagnosing people as a problem, but recognizing that the water in which they're swimming is tainted. I remember early on in my midwifery training reading a nursing text, and in the beginning of the nursing text it goes through, okay, here's this cultural community, and this is what could be wrong with your ability to treat them as a nurse. And it goes with all these terrible stereotypes, right? It's like, the Asian folks might only want to eat rice and chicken. I swear, this is what's in a textbook. That you may not know who all the black people are in the room. They may not be related, but they would tell you they're related. And these are listed as problems for the nurse to overcome, that if they can get them to stop doing this, that they can do their care. And culturally competent care turns it on its head and says, here are all the things going for folks. Here's who people are, and your job as a provider is to engage with that, see that as the beauty of the person sitting in front of you, and that this is what's working for them, and amplify that for their own healing and healthcare, and that their healing might be different than your definition. And I think that what we see so frequently, particularly in maternal health care, is this blaming of the victim over and over. If these women would just do this and stop being like this, then they would live. And we have to, when we're having this conversation, we have to stop blaming people for their own outcomes and start looking at how everyone else is tainting the water in which they're swimming to grow their babies.
For that reason, I tend to use the phrase structural competency instead of cultural competency, because I think that allows us to get at the water, right? And to really understand all of the structural factors and the role that structural racism is playing in the ways that that women are being treated when they are in those clinical encounters.
One of the, is that on? I think what you're touching on is what's called trauma-informed care as a foundation, and I don't know how many students have heard of that expression, but it's from this study, which is actually the most important public health study that too many people know nothing about, and it's called the Adverse Childhood Experiences Study, the ACEs study, right, which was done in the late 1990s. It's really important if you're going to work in healthcare to understand the ACEs study and the implications of it, also the shortcomings of it, and the next stage ACEs, the work that needs to be done. So the ACEs study was done in a predominantly insured, Caucasian, college-educated population in California. And they did, I'll just take just 2 minutes to talk about the ACEs study. So it was 17,000 Kaiser Permanente enrollees, so privately insured, college-educated, mainly white. And what the researchers did, that they asked them 10 questions about their childhood experiences of exposure to abuse, physical, emotional, and sexual abuse, childhood neglect, and household, what they call household dysfunction. So did you grow up witnessing domestic abuse? Did you have a parent incarcerated? Did you have a parent with mental illness or substance use? So they asked these exposures to what they called ACEs, adverse childhood experiences. And what the big findings are, and this is in the late 1990s, was that to everyone's surprise, ACEs were really common, even in this highly privileged community. So that was one. The second is that the higher your ACEs, meaning the higher your exposure to adversity as children, the higher your risk as an adult of things like depression and anxiety, which isn't that surprising. The more bad things that happen to you in childhood, the more likely as an adult you'll struggle. But one of the surprising findings is that not only is your risk of adult depression and substance use and struggle higher, but also the higher your ACEs, the higher your risk of adult diabetes, cancer, heart disease, things that we think of as physical illnesses. So the big finding of the ACEs study is that your body is actually connected to your head. Right? It's like the mind is in the body and in the mind. It's not just housed in, it's not mental illness and physical illness, it's actually integrated illness. And so what the ACEs study found was that, again, this ACEs not only predicted long-term adult physical and mental health struggles, but also things like not finishing high school, not unemployment, work absenteeism. So it had all of these implications for adult functioning later on. So this study was done, again, decades ago, and it's only, I would say, in the last 10 years or so that people are really saying, well, what does that mean for health? Like, we are just treating, you know, in the mother-baby program, we use the metaphor of a tree. So the leaves are symptoms like depression, anxiety, or diabetes or hypertension. And I think this Western medicine leaf approach is part of the problem because it ends up neglecting the traumatic roots of symptoms. So part of cultural care, why it's important is, there's so many reasons, but I would say it acknowledges the history that went into the person that you're meeting. It's not just, again, the symptoms. It's really understanding where people are from and what's happened to them.
I just wanted to reiterate. Thank you. And that trauma-informed approach, it needs to be wholly integrated, right? Because none of these disparities can be addressed in a silo because people don't live in silos. And so it's at the crux of this, whether you're talking about our schools, where we know that trauma is a barrier to learning, and people often other who is impacted by trauma and stereotype who that is. And so, you know, trauma is any disruptive life event. It's hardship. And that is transcendent. It doesn't discriminate. And even though there are some communities and zip codes disproportionately based on the overlay of policies and decades of neglect and under-resourcing and just generational sort of even ancestral trauma that is being passed along, you know, the base of trauma is growing within our school system alone. You know, in our Boston school system, we have 4,000 children experiencing homelessness. But we also have children who, because of gentrification, have been displaced. And if they've experienced as many as, you know, 5 moves in 8 years, that trauma is akin to what a child experiencing homelessness has. We know that food insecurity and hunger is trauma. Poverty is trauma. Fear of deportation is trauma. And yes, exposure to gun violence, domestic violence, violence in all its forms. So within our school systems, we need teachers that instead of asking, what did you do, are going to ask, what happened to you, right? You know, that's the switch. And the same is true, you know, for healthcare. But it really does have to be completely integrated. I think it informs the questions that get asked. Whether or not someone is going to ask a Black woman presenting before them about fibroids, of which we, you know, are disproportionately, you know, suffer with. So.
Or at childbirth 4 times higher than their white counterparts is somehow to do with, right, the ancestral and generational traumas we were talking about, because we know that socioeconomics does not have an impact on this rate. It doesn't matter whether you are a wealthy, educated Black woman or you are, you know, a young woman who has not had an education and is poor. The fact that you are Black is really where the barriers are and where the system is failing you. Congresswoman Pressley, I know that your Health Mommies Act deals with access and availability of doulas. And so I wanted to have you maybe address what exactly your bill does and why availability, increase in availability will be impactful in addressing this issue. And then maybe you all can chime in. If I was just to share my own story, with the birth of my first child, my daughter Isra, I had a doula. And there were many amazing positive things in that experience of having the doula. It allowed me, even though it was my first child, to really have the least pain in giving birth, because I was able to stay home and manage my pain without any medication. And I didn't really arrive to the hospital to give birth until maybe 40 minutes before she arrived. And I don't even remember accessing any pain because I was so relaxed. But once we got to the hospital, some of that cultural competency came into play because my whole family showed up at the hospital. And like literally, and everybody started praying in a language that my doula did not understand. And my doula started having lots of anxieties. And then I started having lots of her anxieties. And so while she and the people who were supposed to provide care for me were supposed to be responsible in keeping me calm, I was now responsible in keeping them calm. And I had a directive that stated who was going to show up, and the fact that 20 people might come, but it still didn't change. And so there are, benefits that you can expand on, and why we think that it's important to have doulas, and then maybe where some of the gaps exist and how it's being addressed in the education system for them is maybe we
Sure. So, doulas help in a number of ways, and it's one of the tenets of the bill that I'm most proud of. We know nearly half of all pregnancies are covered by Medicaid, and about a third of those are C-sections. And so doulas, particularly when they are community-based, meaning they come from the communities in which they serve, can lower C-section rates by as much as 60%. They can also meet the culturally and linguistic needs of pregnant people, offer prenatal postpartum visits, breastfeeding support, referrals for other wraparound services like transit assistance, financial support, mental health resources, substance abuse counseling, and incarceration advocacy. Now, a recent study showed that 87% of women with community-based doulas were still breastfeeding at 6 weeks, compared to 61% of a comparison group. So it's important, that we increase access to these structurally, culturally competent, community-based doulas for all the reasons that I've cited. And it's also important, we can't forget about this workforce, that we pay them what they are worth. In order to sustain this critically needed workforce, that really does mean a living wage. And as I mentioned earlier, within the Massachusetts 7, about 40% of those pregnancies are covered by Medicaid, and that is true throughout the country. And so expanding that coverage from 60 days to a year, because many of those complications occur, well beyond that 4-month period, will also be critical. And then also increasing the use of telemedicine. I think this strikes at the heart of so many of the disparities that are the consequence of unequal access, right? And so
many years, and so they're not working. And so I think one of the things that has to happen from federal to the state and also within the states is that testing new models. Now we know that within the American Indian communities, family spirit model works because it's culturally competent and it's working. And so during the Republican administration, we worked on expanding family home visiting and and expanding to nonprofits who have community health workers and doulas to really have access to go into homes. And so, but that is not still enough, so we need more further legislations to expand that and have doulas and community health workers actually getting that power to go into homes and not limited to nurses. I'm not against nurses, my mother was a nurse, but we have to think about the cultural part and ways that family home visiting can help, because part of it is that it will eliminate disparities that associate with information, access to information, literacy early on when the mothers are pregnant, whether it's exposure from chemicals or how to take care of their babies. So I think expanding that service and including more the scope of practice, I think will help.
Before you address that, I just wanted you to bring in, I think that there is, right, a different understanding of what structural barriers are. People can put that down, right? Like housing can be a structural barrier. There are a lot of things that can go into our ancestral generational traumas. All of those things could go into that structural barrier. But then there are some actual cultural barriers that exist, right? You might not understand that there's a positivity into having a doula or a midwife in comparison to wanting an actual doctor. Amira knows this in many of our communities. There is a preference in who you have and trust that's associated with that. And so how do you all navigate all of that in the research, and how is that impacting, I think, the access that people have?
We'll hear from those that will say, why is everything about race? And what I want to just offer is that we know that the best policies are informed by data. So when we give you the data that supports that folks are at the bottom, it is relevant. And it really is about training to inform that competency and that awareness. I do a lot of work in the space of gun violence prevention, and our trauma center, recently we had representatives at an office meeting talking about a surge in gun violence in my district. And they said, we were only trained in how to repair these wounds. It is only now that I'm asking myself, who is in front of me? What brought them there? Why do they keep coming back? And that is about training. Their training as healthcare professionals and ER doctors was never trauma informed. So, I just appreciate you making that point, that although well-meaning, that folks can be harmful.
Well, I will say too that systems at Hennepin Healthcare, which is the hospital I work at, there's a group of us that were very committed to bringing trauma-informed care into our health system. And so we started with learning about ACEs and whatnot, but decided collectively that actually we needed to start with historical trauma as the foundation, because we needed to have some shared understanding of how did we get here. And so we started with African American historical trauma, and also to some degree Native American historical trauma, and trained maybe 600 people so far in the hospital. And it was fascinating because for a hospital that is committed to serving underserved people and wants to provide exceptional care without exception for anyone, we had never talked about racism in a public forum. So it was uncomfortable, I would say, for a lot of people. It was actually such a relief to others, and I think it's really opened up this dialogue. So it's really viewing this historical trauma as a foundational first step to understanding how did we come here. And I've heard this week from people that had worked together for years and years and years, that they learned things about one another that they had no idea about, what the day-to-day experience of their coworker was like, just things that they had never thought about. And so I think it's really on this very micro, personal, one-on-one level that I think a lot of change is going to happen, in bringing trauma-informed awareness to providers. It's really just doing the hard work of looking in the mirror at your own biases.
On training, so that they had the competency to handle, right, sexual assault cases and can interact properly with the victims themselves. And I am hopeful that there are trainings like that getting done for medical students. We'll take one more. Okay, yeah. Dean?
Thank you.
Maybe you could tell us what is happening in the School of Public Health and if we're actually going to get an actual impact out of this conversation.
Yes, I'm John Finnegan, I'm Dean of the School of Public Health, and I'll tell you one of the things that's happening in the School of Public Health is Professor Rachel Hardeman. So, and I would say so many others, including Amira Adawe, who is one of our graduates too. So, I wanted to ask you a question. So much of system change. How could we train health professionals differently in this arena? Because it's a systemic issue, and so many of the good programs in Kansas City and many places around the country are doing what they do because they can't get the systemic change that they need to be able to change the kinds of disparities that we're seeing. So I wonder if you would be willing to talk about what kinds of things we could do in training physicians and nurses and public health folks and pharmacists and dentists and everybody else that's involved in the system.
They've got their mics ready.
Yeah, we talk about this a lot, actually. One, you can make it admission criteria that you understand these concepts. So as someone outside of that, you could make it admission criteria. Someone gets to that level of education and has not done one-on-one work on anti-racism and anti-oppression, we should all be a little bit ashamed. This should be happening long before then. Two, embed students with community. Bring them out to the community. We want medical students with us learning what we do. Let's tear down the gulf between the community and the institution so that we can all learn and work together and deepen. And three, there has to be diversification of the workforce. As far as we know, we only have one African-American labor delivery nurse in the Twin Cities, maybe? I want to be wrong? So we have to be looking at how we do that.
So Rebecca and I talk about this all the time, and those are our three points. I would also add, minor plug, but my course is a required course.
Hopefully the rest of academic health center will do similar thing and to intentionally
health as a standard of care or standard of prenatal postpartum care. It's an opt-out versus an opt-in. Currently, you have to be symptomatic enough and depressed and anxious enough that you get flagged and then referred, and it really should be, emotional support is universally needed by all, families. So I think it's really changing the frame of mental health is not a kind of marginalized afterthought when people are struggling. It's really, again, just an essential, integrated part of prenatal postpartum care.
Very experts, very prescriptive, pun intended, and I endorse all of that, and I thank you for hosting us. And I want to give a plug and just say, one of Omar and her leadership on a specific issue is that what I'm concerned about is the growing number of young people who want to do the work of healing community and healing the world, but are so fearful of being choked by stupid debt that it is informing the choices they are making about the contributions they seek to make in the world. And so, thank you, Representative Omar, for your leadership on the issue of student debt, and let's cancel it.
Before we go, I wanted, this is one thing we talk about a lot as new members of Congress, right? What are we doing to shape a new narrative about an issue that we care about, that we feel like isn't being talked about or addressed in the right way? How do we change the conversation about how our communities are talked about in the media and in public? And so, what in regards to the conversation we are having today, would you like the people to walk away with as they leave this room? How do you want them to address this? And ways that what are the quick talking points when they run into someone, why this problem exists and why they should care about. So if you were writing your own headline, what would it look like? And we'll start with you. We can start anywhere. But, so just a quick line, right?
I think my talking points would be, and this is one that some of my students who are in the audience already know, is that racism is a fundamental cause of health inequities. Two, that we collectively have the power. Collectively, we have the power to do something about it, to dismantle it. We have to know our history, as we've talked about quite a bit today. We cannot continue to take a historical approach to the policy that we put into place, the policy that we support, both at a state, federal, and even within our schools and our institutions and our healthcare systems. We cannot continue to ignore the history of racism in our country and how it has impacted the lives, the well-being, the mental health of Black and brown people. I would say that structural racism was built on purpose and therefore it must be dismantled on purpose.
Think about environmental exposures as you think about early childhood and reproductive health. That narrative has to be there, and that it's not isolated from other issues. So keep that in mind, and please educate other people about issues that impact communities of color and ways that can be addressed.
I think of the late great Senator Wellstone's quote of we all do better when we all do better. And currently too many of our children are struggling and suffering. So we live in a community where if you're black or brown baby, you have more than twice the risk of dying. And yet we're still sitting here like we should be running like our hair is on fire, right? I mean, how can this be? And I think this idea of the structural racism has to be intentionally dismantled, and it has to start with the individual. Is really important, that the cradle to prison pipeline that Marian Wright Edelman talks about is real, and that we all participate in it, in perpetuating it or dismantling it. There's nothing in between.
As I said at the outset, I'm not one that leans towards brevity, so I will not venture to offer a headline, but I will offer some action items, and that is, please use the power of your collective voice to express equitable and sustained outrage and organizing and mobilizing about every justice issue, including health, including this issue. And I want you to specifically lobby those to be co-sponsors and to support the Healthy Mommies Act. And then,
Already on it.
okay. But you have platforms that are influencers and, values engineers and social architects and, activists and agitators and disruptors and lawmakers in your own right. And so your leadership may get it, but we need your help in getting others to get it. And then the last thing that I want to say is an action item, because I'm saying this everywhere, is the census, the census, the census. I don't know about the 5th district here, but I can venture to guess that this is a harder to count district, because it is true for the Massachusetts 7th. If the federal government doesn't count you, you don't count. And so when we talk about the amplification of lived experiences and stories, and that influencing policymaking and federal investment, it begins with the census. This is about representation. This is about federal funds for public schools, for Medicare and Medicaid, for community development block grants, for housing, for other block grants, for language access. And so please make sure that you are counted, and that the people that count in your lives are also counted, because Minnesota's 5th and every district throughout this country is worthy to be seen, to be heard, and to be invested in. And I need you to be foot soldiers in that work.
For all of you for being here to have this important discussion, all of you for coming. Minnesota is #1 worst in all of the lists of things for brown and black people. And what we are doing, right, as part of the visit that brought Ayanna Pressley here, is to talk about ways that we can deal with some of the racial disparities that exist for the black community. And so today we got to have a really wonderful conversation around maternal mortality rates. Tomorrow night at the Guthrie, we are going to have an important discussion on mental health. And so I hope all of you are able to join us as we talk about the structural and systematic barriers that exist. What are some of the ancestral and generational traumas that cause mental health, and how do we develop proper language as a community and as a system to addressing it. Because one thing that I know is that if you don't have the language to talk about anything, you are certainly not going to address it. And I know my own Somali community, and in our own language, we don't have language to to talk about mental health. And so we're not addressing it, and I know that is true for many of my sisters and brothers in the Black community. And so if you're available tomorrow night at 7 p.m., join us at the Guthrie. Have a great day. Thank you so much for being here.
Thank you.